Bismillahirrahmanirrahim. Um, so our topic for today, as mentioned earlier, that is approach to psychiatry stations. Um, Psychiatry stations, as all the stations in PLAB 2 go, they sort of follow the same format. Like we start, and first of all, we introduce ourselves. Grips comes, and then we start with a presenting complaint, and then we sort of start exploring the presenting complaint further. The only difference comes in one is should be the one difference should be in our general temperament and the way that we are approaching the patient. We should be in every station of tab 2, like we should be extra we should be very careful with the emotions of the patient. We should be very sensitive, and our interpersonal skills should be very good in and these all of these things, they matter more in case of psychiatry stations. And what I was planning that we'll do that in this session we'll just go through several key points that we need to know to perform well in a psychiatry station, and then hopefully in another session we'll go through scenarios one by one, and we'll maybe if we can we'll try to practice them and see if we can learn better in that way. So here, rather than going through a structure of each scenario, there are certain key things, certain points that we should remember. So as I hope you can see on the you can see on the screen the key points that I have written here. The mnemonic, this is MC Famish. Like we use different kinds of mnemonics in history while taking history in PLAB 2, like Meftosa and Desa and so on. So similarly, when we are taking history from a patient with psychiatric illness, we need to make sure that we ask each and everything that is written on this slide. Again, it's not necessary that each and everything would be relevant in each scenario and might be skipped, but it should be, at least it should be in our mind, and we should at least go through that this screening checklist in our mind to make sure that if any of this is relevant, then we can ask that. So M stands for mood. Mood is sort of it will come in every scenario of psychiatry, especially more relevant in major depressive disorder. Like we and how can we ask about mood? We can ask how have you been feeling lately, and there are certain other questions regarding mood which we can ask, which we'll go through in detail later on. C stands for cognition. As cognition is especially relevant in two scenarios. One is dementia, and second is psychosis. So, if a patient of dementia comes to you, but the presenting complaint would be difficulty in remembering things, memory difficulties, or maybe confusion, and it is, and also in delirium. So whether the person comes with acute confusion, chronic confusion, memory difficulties, or if the person comes with symptoms which are suggestive of psychosis, then we need to make sure that we perform a screening of cognition. And cognition includes checking orientation. Can you please tell me? And we can also we should signpost before asking questions related to cognition, like my questions, they may seem a bit too simple, but please bear with me, and then we can ask them, right, can you tell me which day is it? Can you tell me what's the date? Can you tell me which year is it? Can you tell me the name of the city? Can you tell me who I am? Can you tell me who you are, why you're here? Like this, we can check the orientation. Then we can move on to check other aspects included in the mini mental state examination, like recall and attention, concentration, which we'll go through in detail when we study MMSC, mini mental state examination. Then comes F. F stands for family, friends, forensic, and finance. So just a minute. Okay. So family and friends is really important in all psychiatry stations to ask, like ask about the social status of the patient, ask if he has any close friends. And the rationale behind asking these questions is to ascertain the support group that the patient has, to make to assess whether he has good support at home, because this answer to this question can in fact influence the decision that we take regarding his treatment, whether his treatment will be outpatient, or we're going to have to admit him. It all depends on a lot of factors. One of them is the presence of a support group at home. Then comes forensic. I don't think that in any uh, psychiatry scenario that has yet been asked in PLAB 2, there is any significance relevance to forensics. But generally, it is recommended to ask while taking history from a psychiatric patient, because certain psychiatric disorders have a predisposition to certain violent behaviors, which can lead to which can show up in forensic history. Finances are really important in case of hypomania or mania. So we can ask the patient, or we can ask, if we're asking the relative, we can ask that has the patient been spending too much lately? How has he been going to shopping quite often, or has he been giving to charity more often than usual? So this can suggest that the patient is having an episode of hypomania or mania. So that's the main significance of asking about finances. Then A stands for alcohol, allergy, and other drugs. Again, every psychiatric illness, it might be induced by recreational drugs or by addictive substances. So alcohol or other drugs, they need to be asked. And even if they're not induced, the psychiatric illness is not induced by these substances, there is a high propensity for comorbid substance use disorder. So we need to ask, like after we ask that you in regular, like we ask in DESA, do you smoke, do you drink alcohol, and then we should also ask, do you use any other recreational drugs? Allergy, that's just like in any other scenario in PAP 2, this is the structure includes allergy. Maftosa is allergy. Then M, medical and mental, that's also just to fill in the space maybe. So we like in any other scenario, we ask about the past medical history, and very important about the past psychiatric history, because again, a past psychiatric history of the patient can change our decision regarding the treatment. I will give an example, like if a patient has a long-standing psychiatric illness and he now presents with an attempted suicide, you'll be more inclined to admit that patient as compared to a patient who does not have any past psychiatric illness and impulsively made a choice due to a quarrel at home and attempted suicide. You might be willing to discharge him and see him on outpatient basis. Then I stands for insight and impact. Again, very key factors. We should insight is really insight really plays a key role when it comes inside when it comes to the scenario of psychosis. The patient will not have insight. So even the very definition of psychosis is that the patient is detached from the reality and is living in his own reality. So of course, is not going to have insight that what he is. And he's not even going to entertain the possibility that what he is seeing or what he is listening or what he is thinking, it might be the result of some illness. So, and again, how does it influence the treatment decision? If a person has insight, if the person has insight, we can maybe we can discharge him, and maybe we can see him on outpatient basis. If we think that he is competent, he's taking responsibility of his own health and he's willing to get treated, and he can come back. If the patient lacks insight, then that is again an indication for admission in patient treatment. Then impact especially is relevant when it comes to depression. Like when in PLAB 2 we have a scenario in which a patient comes with depression, then we're going to have to screen whether it is mild depression, moderate depression, or severe depression. And on the basis of that, we're going to decide whether we're going to refer the patient for talking therapy, CBT, or whether we're going to refer him for antidepressants to a psychiatrist, or whether we're going to refer him on emergent basis to the hospital. So impact, so broadly speaking, like if a depression has suicidal ideation, we categorize it as severe depression. If the depression is uh, significantly influencing the daily activities but does not have suicidal ideation, we can say it's moderate depression. And the if depression is not significantly hampering the daily activities, and of course, and there is no suicidal ideation, of course, then of course we can maybe characterize it as mild depression. And just a rough screening, we can characterize it as mild depression, and maybe we can refer the patient for talking therapy. S stands for suicide. There are two scenarios of suicide in PLAB2, and it's a very important and very famous scenario in which a person comes with paracetamol overdose, and then you have to assess whether he is. You are in psychiatry, and you go to the medical ward, you go to the medical emergency to see him, and you have to assess whether he is safe to go home or whether he should be admitted in the psychiatry ward. And there is another scenario of suicide when the patient has taken paracetamol overdose, and this time you are in the medical emergency as senior house officer, and you have to take a medical history more. You have to assess whether the patient is medically stable. You have to take bloods and discuss the treatment plan with the patient. So suicide again relevant in all psychiatric illnesses, and a very important marker which will be the basis of your decision whether you're going to discharge the patient, you're going to admit the patient. And H stands for hallucination. So again, the MC famish, this will be on the back of your mind whenever you're taking history, whenever you're exploring the presenting complaint in P1 part of the structure of the history. But you don't necessarily need to ask everything. For example, in a case of depression, uh, if there is mild depression or moderate depression, then I might not need to ask about hallucination. Only in cases of severe depression, where I would be suspecting that the depression might be associated with psychotic features, where I ask about hallucinations or delusions. Similarly, um, in cases of, for example, cognition, let's say the patient has dementia, then again in that case, the impact of the memory difficulties, impact on the daily activities, that would be, for example, more relevant than the other aspects. So try to, at least in the start, I think, let's say we should try to ask them, and gradually, as we'll practice, we can learn to focus on the more important aspects in each scenario. So this was one important slide which shows us that while exploring the presenting complaint, whichever it is, the presenting complaint gives us an idea that the station is of psychiatry. Like if the presenting complaint is either low mood, it goes towards depression. If the presenting complaint is memory difficulties, it goes towards dementia. If the presenting complaint is confusion, it goes towards delirium. If presenting complaint is feeling too high, it can go towards mania. If the presenting complaint is is you're supposed to talk to him about some drinking habits, it goes towards substance use disorder. Or if the presenting complaint is that the patient was brought by her mother or by her relative, and the patient has been acting odd lately, well, it might be a scenario of psychosis. So the presenting complaint does give you an idea that the station is of psychiatry, and thus when you're exploring the presenting complaint, you should make sure that you use this mnemonic, and you make sure that you complete this checklist to elaborate the presenting complaint and to collect all the relevant data. So um, there is another this is the slide that now we're going to discuss. In cases of psychiatry, and this is not only in cases of psychiatry station, in all cases of PLAB2, in all scenarios, in all stations, it is highly recommended that that we keep our eyes and ears open. And if the patient is, there is a visible, there's something going on with the patient is acting odd, or the patient is acting in a certain way, if then you should acknowledge that behavior, not only because it might be related to the concerns of the patient, which in turn would help you in formulating a good management plan. Not only that, but also it gives a really good impression to the examiner if you are acknowledging the behavior of the patient, because it shows that you have not just memorized everything, and you have not just come here with some information in the back of the mind. You're alert, active, and alive, and you're focusing on what is in front of you rather than what you've read in the book. So but especially important, like I mentioned, the interpersonal skills. It's a part of interpersonal skills, and it's important in all cases of PLAB too. But all these skills become more relevant. They become more important in psychiatry patients. So you have to acknowledge the behavior of the patient. For example, a patient with depression, he might be, let's say, feeling low, and he might not be making eye contact. He might be looking down at the floor. So it's uh, it's always good to acknowledge that behavior, because that will help you in forming rapport with the patient. And as I mentioned, that would help in giving a good impression to the examiner. So, if the patient is feeling embarrassed, you should acknowledge it. I can see that you're feeling embarrassed. If the patient is feeling scared, like we remember in a patient in non-accidental injury, the patient looks scared and looks to the door again and again. So you can say that I can see that you are scared, or I can see that you're looking at the door. Is everything fine? So these short sentences like that, they can really do the wonder of breaking the ice, of building rapport, and just making us distinct from other candidates during the exam. So behavior is for you to acknowledge, and when it comes to appearance, you you do not necessarily, in fact, you should not make a comment on patient's appearance, because it might seem a bit less sensitive. Rather, appearance is for you to note, so that you can use it during your making a diagnosis and during the management plan. For example, if the patient's appearance is unkempt, if the patient is appearance is dirty, then of course you should not mention it. You should not acknowledge it, but of course you should keep that in mind. And while making a management plan, you should, because that of course gives you an idea of the impact of the illness to the patient's daily activities. And then comes language and speech. Again, language and speech is for you to notice, and it can give you some idea about about the psychiatric illness if the patient is suffering from. If the speech is of low tone, and if the speech is of low tone, let's say, which would be seen in depression, in as opposed to pressured speech, which would be seen in mania. So again, uh, I would again reinforce this advice that in every case, in every station of PLAB 2, we are supposed to acknowledge the behavior of the patient, and we are supposed to make a good observation regarding the appearance, the language, and the speech of the patient. But this